Ladies and gentlemen, my name is Alexander Stepanenko. I'm a member of MCS team of German Heart Institute in Berlin, and I would like today to share with you our experience regarding concomitant surgery during the VAD implantation. Implantation of ventricular assist devices is now an established treatment option for end-stage heart failure. However, additional cardiovascular pathologies requiring concomitant treatment during the surgical VAD placement has been addressed. Hence, some pathologies may render VAD implantation or make it function difficult. Also, there are some clinical situations which are prohibitive for VAD implantation. At time of VAD insertion, persistent foramen ovale or any intracardiac shunts had to be closed. In case of pulmonary embolism, thrombectomy is possible. However, a temporary right ventricular assist device probably will be required for a postoperative period. In case of infarct VSD, close it if possible, or think about indication for use of a total artificial heart if necessary. In case of coronary artery disease, revascularization, especially for protection of right ventricle, right coronary, or LID to protect intraventricular septum is maybe of value. Ascending aortic aneurysm, graft replacement or a reduction plasty is possible. In case of left ventricle aneurysm, resection and evacuation of LV thrombus is possible. If patient has a mechanical mitral prosthesis in place, we leave it. We do not exchange the prosthesis. From our experience, these patients did not present any hemodynamic disturbances having a mechanical prosthesis in the mitral position. If a patient has a mitral insufficiency, we leave the insufficiency. Usually is significantly regradient after the initiation of LVAD support. In case of mitral stenosis, we have to treat stenosis because it's make the function of LVAD impossible. Mechanical aortic valve in place. We replace with biological prosthesis. In case of aortic valve regurgitation, conventional biological valve replacement may be of value, together with interventional aortic valve replacement, use of endovascular procedures or alternative ways to close of aortic valve with patch, suture, or interventional occluder. The tricuspid valve regurgitation. Tricuspid valve repair is still be in big discussion and debatable. The repair is indication for repair based on geometry and the function of right ventricle and the tricuspid valve annulus. This case is presenting the patient with a coronary disease, 30 years old male, admitted to our hospital in the shock condition with EIBP support, high catecholamine dependent, presented the lesions in LAD and marginal coronary arteries and also mitral insufficiency grade 3. We perform mitral valve reconstruction using the artificial ring, coronary artery bypass grafting, and primary implantation of hardware LVAD. After the surgery, patient recovered and has been discharged. In the outpatient study, he presented a partial recovery with ejection fraction of 35 to 40%. And in this case, it shows that partial recovery as a possible biological backup in case of the failing mechanical pump is maybe of great value. This is the story of 52 years old male suffered by valvular cardiomyopathy with mitral stenosis of grade 4, aortic stenosis grade 3, together with aortic insufficiency. We performed biological aortic valve replacement, biological prosthesis in mitral position, LVAD implantation, and also right ventricular assist device placement with oxygenator in the circuit due to pulmonary failure. We could explant oxygenator on the postoperative day 2, and after 19 days of right ventricular assist device support, we explant it, and patient now supported with LVAD only over than 2 years being at home. At these slides we present the study performed at our institution. Patient with aortic valve pathology undergoing assist device placement in shock condition, INTERMACS 1 and 2, presented poor survival, high requirements of RVAD, and then so in patients with cardiogenic shock and additional aortic valve replacement requirements, the overall outcome is impaired, and alternative techniques should be considered to address the aortic valve pathology. In stable patient, simultaneous aortic valve replacement and LVAD implantation are not associated with impaired outcome. In case of acute infarction at the left ventricular apex, wait some days on ECMO or medicamental therapy, and then implant left ventricular assist device using the connection to the LV apex with additional sutures. In case of extensive infarct, implantation of total artificial heart may be required. In case of acute aortic dissection, replace ascending aorta and connect the outflow graft to the graft. In case of chronic anterior LV aneurysm, resection is not necessary. We use aneurysmal wall for securing of LVAD inflow cannula. The chronic posterior LV aneurysm, we leave it in place, or we do thrombectomy and resection and primary implantation of assist devices. Mediastinitis is a very dangerous situation for concomitant use of ventricular assist devices. Treat infection first. One of the options is the implantation of peripheral ECMO and the stabilization of infection situation. Intractable severe ventricular arrhythmia, the implantation of defibrillator may be of value. In this case, a 47-year-old male suffered by acute aortic dissection type A, Stanford. Bentall procedure with implantation of mechanical valve conduit SU10 25 mm has been performed. However, intraoperatively stone heart developed, probably due to dissection into the coronaries and perfusion problem, myocardium. Decision to implant a total artificial heart has been made. After discharge from the hospital, patient spent 322 days on support until the heart transplantation, and after heart transplantation he is doing well. In this case, patient with Marfan syndrome suffered by chronic biventricular heart failure, having an anamnesis several intervention in aorta ascendens and descendens, having the mechanical valve conduit in ascending aorta, underwent biventricular hardware implantation together with the replacement of mechanical valve conduit to a biological one. Patient is discharged and ongoing over than 3 years. This individual suffered by ischemic cardiomyopathy. He had also LV aneurysm and mitral insufficiency grade 3. He underwent LV aneurysmectomy, mitral valve reconstruction, and placement of left ventricular assist device. In this individual, after left ventricle aneurysmectomy, we performed LVAD placement at site of previous aneurysmectomy. Patient is ongoing concomitant 3 years and doing well. In case of acute infective endocarditis, eradication of infection is of great value. Constructive pericarditis, in this case at least partial pericardectomy had to be performed together with assist device placement. In case of chronic increased pulmonary vascular resistance, maybe these patients require permanent biventricular assist device. In case of complex congenital heart diseases, single ventricle, failed Fontan circulation, post bidirectional Glenn and shunt procedures, important is to close all existing intercardiac shunts, leave bidirectional Glenn shunts in place, perform first a Fontan procedure, leave the Glenn shunt and implant an LVAD. In case of failed Fontan, support of systemic ventricle with LVAD. This case presents 24-year-old man with DTGA and correction by thinning operation as neonate. He has been admitted to our institution with a chronic heart failure. After the evaluation, we performed implantation of LVAD into left ventricle, which is morphological right ventricle. In another individual with congenitally corrected transposition of great arteries and state post-cerebral palliation in childhood and adulthood, we implant left ventricular assist devices off pump again into functional left ventricle, which is morphological right ventricle, connecting to the ascending aorta. Both patients with support of systemic ventricle has been discharged home and ongoing over than 1.5 years. Introduced by Professor Hetzer and Professor Pasic, we use for a permanent support in the patients who with previous cardiac operation, left lateral thoracotomy and connection of left ventricular assist devices from the left ventricle apex to the aorta descendants with the good clinical outcomes. I'd like to conclude. Some pathologies in addition to heart failure may render LVAD implantation, such as lesions at the site of the inflow at the apex and lesions at the site of the outflow ascending aorta. Specific individual techniques must be applied accordingly to overcome the difficult problems. Infection at the site of LVAD must be treated first. One of the options is implantation of peripheral ECMO and stabilization of infection situation. In patients with a previous or repeated sternotomies, we prefer left lateral thoracotomy approach when the goal is permanent assist device support. Special consideration must be given to the older age, severity of cardiogenic shock, and multi-organ failure, where additional procedures may likely increase risk of LVAD implantation.